I must also say we are very pleased and gratified this year, in May of this year, Dr. Satcher, former Congressman Kennedy, and I did a program at the American Psychiatric Association to remind ourselves the richness and the inspirational role that that report the Surgeon General had for all of us, for Congressman Kennedy, and for myself as a practitioner and as a professor. And we really need to take stock of those accomplishments and bring them up to date and put them into practice here. Dr. Satcher at that meeting was also honored with a very special award of the American Psychiatric Association, which is one of the most coveted awards given to anyone in the APA, namely the Human Rights Award. So it is really with great pleasure to introduce to you Dr. David Satcher.
Well, thank you very much, Elliot, Dr. Sorrell, for that very kind introduction. I am delighted to be here. I'm delighted to be a part of this effort. Those of you who know me know that I love meetings that have goals. You want to go somewhere, you want to establish something. And that's the attitude I took for the Office of the Surgeon General. If we were going to release a report, the question was, so where's the report supposed to lead us? And that was certainly true of the mental health report. I bring greetings from the Satcher Health Leadership Institute at the Morehouse School of Medicine. I know some of you are very familiar with Morehouse, because I know back in the early days, there were many people from Africa who were involved with the development of Morehouse School of Medicine. And then we had students from Africa who finished medical school in Morehouse and came back to Africa to provide leadership in various ways. So it's great for me to be here. I first came to South Africa in 1994. I remember it as if it were yesterday. I had just become director of the CDC, the Centers for Disease Control and Prevention. And Helene Gale, whom some of you know, was my guide for foreign travel. We had gone to Tokyo for the AIDS conference. And the plan was that we would come back from South Africa to visit the CDC's program in HIV/AIDS. And some of you may even remember Jacob Gale, who led that CDC effort here. But I came to South Africa with Helene and spent about a week here. And that was sort of when I fell in love with South Africa. So I've been here many times since. Of course, during the Clinton administration, some of you will remember the Gore and Becky agreement. Well, I'm sure there are good memories and bad memories. But it was an agreement between the United States and South Africa where the vice presidents took leadership. So I was assigned to the health component of the Gore and Becky agreement and had a chance to spend a lot of time in South Africa and got to know a lot of people. And I tell people all over the world that Cape Town is probably the most beautiful city in the world because I like the outdoors. I love Table Mountain, and especially Cape Point, where the mountains and the ocean come together. When you've been as involved as I have and travel as much as I have, you put off a lot of things. You say, well, one day when I'm not busy, I'm going back. And so I promised my wife that a lot. I'm going to go back there and take you. And two of the places that I actually, my wife has I came back to South Africa and spent a week at Cape Point. Then went to the Taj Mahal in India. But I've had the opportunity to people in South Africa from the standpoint of medical education, community programs in HIV/AIDS. After I left government, I served for 9 years on the board of the Kaiser Family Foundation. And some of you are aware of the Love Life program that Kaiser funded, $60 million. And Kaiser is not a foundation that funds programs as a rule. But we thought that this program was important. And that was before PEPFAR, before that we had PEPFAR. So I've had some great experiences. There's a glare that makes it difficult for me to see that, but I'll get used to that. The idea of starting an institute, and it wasn't my idea to name it the Satcher Institute, but the idea of starting an institute, a leadership institute, actually came from our board of trustees. I had served as interim president at Morehouse, and when I stepped down as interim president, the board decided they wanted to really capture the efforts I made to develop leadership at the Morehouse School of Medicine. And so the idea of a leadership institute. Now, the Leadership Institute has some deep roots, because when I left Washington, I went back to Morehouse to develop the National Center for Primary Care. And I believe Michelle Durham was a part of that team, right, Michelle? I have a lot to be proud of. But Michelle has done so well. But we hired her when she was working on her Master's of Public Health, I believe. Yeah, so it was great. But I want to say just a word about our Leadership Institute, because I know that that's where you're going. One of the leadership lessons that we like to talk about is the fact that leadership is a team sport. We have about 20 lessons. One is leadership is a team sport. And I'm big on team. I ran track at Morehouse. So I'm big on team. But I was thinking the other day after Chicago Cubs, those of you who follow American sports, after Chicago Cubs beat the Cleveland Cavaliers, I had mixed feelings because I went to medical school in Cleveland. But then I remember hearing a story about another playoff in the 90s, I believe. Anyway, Michael Jordan was still playing with Chicago. And the story is that there was one night in the playoffs, Chicago winning the playoff, Chicago Bulls, when Michael Jordan was playing along with the rookies, Stacey King. Some of you may remember. But it was one of those nights. Michael Jordan scored 69 points. And Stacey King, the rookie, scored 1 point, a free throw. The press can be cruel. So when the game was over, they interviewed Michael Jordan. He was great. But they decided they would also interview Stacey King. And they asked him, what will you remember most about this game? And King said, I will remember it as a game when Michael Jordan and I combined for 70 points. That's what leadership is about, really. Even though, and Donald Trump is realizing that, right? As it gets really real, leadership is about putting together the best team and figuring out a way to function as a team. So I hope that as you plan, as we plan for the Institute, we will remember, and this is a global team because Africa is certainly a global continent without question. The roots from here to America and all over the world are just very deep. So say you're going to have an institute on an African institute, because they have very deep roots. And we're very pleased to be a part of that. The Satcher Leadership Institute, of course, focuses on policy development. It's one thing to do research. It's another thing to provide service, and those are both critical. But ultimately, to really make change, you've got to play policy, right? I learned that really learned it when I was president of Inherit, and we were trying to affect the policy of Nashville General Hospital. But I certainly learned it when I was director of the CDC, and that we can have the best available science, but unless we can translate that science into policy, ultimately it's not going to make that great a difference. So in our fellowship program at the Satcher Leadership Institute, we really focus on working with the fellows in terms of policy development. Policy development can be very challenging. It's great when the science is on your side, but it's not always enough, right? To get the policy in place, sometimes you have to do much more. When I became director of the CDC, Godfrey Oakley had worked at the CDC for many years, and he had one major interest, and that was the whole issue of spinal bifida and cerebral palsy, and he had been able to help show that folic acid fortification of meal and flour could reduce the risk of anencephaly and spinal bifida. But nobody had been able to get Congress to listen. And so when Dr. Oakley came to see me, he made it very clear that the one thing he wanted before he retired was to get the United States to pass a policy of fortifying meal and flour with folic acid. So I traveled with him to China, spent 2 weeks there, meeting with his colleagues there who were doing the research. China had a much higher rate of spinal bifida than we did. And they had done some great research. It did not receive the respect that it deserved. So Godfrey wanted me to meet his fellow scientists there so that maybe we could come back and get our Congress to act on the issue of folic acid fortification. That was 1995. And it was not until 1999 when I was then in Washington as Surgeon General that Congress passed legislation. And I'm only saying that as one example of sometimes the difficulty of getting from solid research to policy. And sometimes, of course, as you know, deeply held beliefs can impact policy more effectively than science. So we have to, so what do you do? Ignore deeply held beliefs? No, you have to find a way to work with deeply held beliefs. You have to find a way to work with culture. This represents our four major areas of leadership development. The first one being health policy. We started that program, I believe, in 2007. And we've now had 6 different group of fellows. Some of our fellows are physicians, some of them are doctors of public health. The one requirement in the fellowship program is you have to have a terminal degree. So the Health Policy Institute is the only one that requires a terminal degree. The Center of Excellence for Sexual Health. Sexual health is another one of those reports that I issued, probably the most controversial, for many reasons, of course. President Clinton was very supportive of most of what I did, but we got sort of trapped with that one because of some things that had been in the press. But we finally did release the Surgeon General's report on sexual health. And after I left government, of course, the Ford Foundation funded a consensus panel. So we've made a lot of progress. The CDC now uses sexual health as an approach to HIV/AIDS, and not just treating it as a disease. What does it mean to take the sexual health approach? It has to do with social determinants of health. It's made a big difference. But the same thing is true of mental health, as you will see later, as you probably already know. Community Voices is another one of our programs. It's been there since the beginning. And it's where we actually work with communities to improve access to care all over the country, not just the community around Atlanta. But we have community relations all over the country. Somebody just sent me a note yesterday the Kresge Foundation just gave us $800,000 to fund a health leadership development program for mayors. We've had 10 mayors to go through our leadership development program, and we've been really trying to focus on the unique needs of people who find themselves in a position being the mayor of a city and knowing that you have some major challenges in terms of health, but trying to figure out how do you take advantage of the resources of your community to really advance the health of the community. So I was very pleased to hear that we've now been funded to advance that program. Some of you probably know the name Johnny Ford, the mayor of Tuskegee, one of the most famous mayors, I guess, in the country, because Tuskegee is such a famous city. If you don't know about Tuskegee, that's a real challenge, because Tuskegee was the site of the research in which 400 black men who were taken advantage of were followed but not treated, so that the government, public health, could learn more about syphilis and how it affected. So sometimes when you wonder why we have trouble now with HIV/AIDS and people cooperating with research, somehow it all ties back to the Tuskegee study and what happened there. Now, if you remember, we were able to get President Clinton to apologize for the Tuskegee study on behalf of the American people, for the black men and their families and that community. In fact, I'll be going back to Tuskegee in February to give the 10th anniversary keynote for the apology for Tuskegee. And the idea was not that President Clinton apologized, but that in addition to that, we put in place programs requiring all researchers, all patient care providers to demonstrate every 2 years that they have the knowledge and the commitment to make sure that patients are treated fairly, to make sure that anybody involved in research are treated fairly. So that was quite a significant initiative. There's also, as a result of that, there's the Bioethics Center at the Tuskegee Institute, where people come from all over the country and the world to study bioethics as it relates to patients and research involving patients. So I think a lot of things have come out of that, and not just an apology. The Behavioral Health Center is actually our largest center. Some of you all know Dr. Glenda Wren. Glenda is a psychiatrist who trained at Penn as a clinical scholar, and after she finished her clinical scholars program, came to work with us at the Morehouse School of Medicine. So she runs the Behavioral Health Center. Glenda has just recently been made head of the Kennedy Institute at the Satcher Leadership Institute. Patrick Kennedy and the Kennedy family just gave us $5 million to implement a Kennedy Mental Health Institute as a part of the Satcher Health Leadership Institute. Now, if you know anything about the Kennedy family, if you know about John F. Kennedy and Edward Kennedy, you might not know that this is a family that's really been burdened by mental disorders. It's a family that's really struggled. And for a long time, maybe even still, they were not, you mentioned the stigma, they were not willing to even talk about it. And along comes Patrick Kennedy, and so when I released my report on mental health, Patrick Kennedy happened to be in the Congress. And we met, and he made it clear to me that he was going to do everything he could to make sure that the mental health report was followed. Now, we had one major mission for the report, one major goal, and that was parity of access to mental health services. Now, if you're not aware of how critical that is in the United States, in Africa, parity of access, you mentioned earlier the lack of resources in terms of psychiatrists and other resources. That lack of access is real in the United States. It's real because shortage of psychiatrists and mental health workers, but also it's real because of the stigma. Because of the stigma, individuals don't seek care when they need it. So often it's very late. Because of the stigma, families can have a child who needs mental health care and not seek it. Because of the stigma, policymakers have trouble passing the right policy. So the main thing we wanted to happen as a result of the Surgeon General's report, we wanted Congress to pass mental health parity. That was our major goal. There were some other details, but that was our major goal. We wanted, and that report was released in November of 1999. And it was not until 2008 that Congress passed the Mental Health Parity Act. So you can't be impatient. It's going to affect policy. It takes time. I'm not saying that we should tolerate that, because I think we are getting better. The Surgeon General's report on smoking and health, and I may have passed it because I'm having trouble. But the Surgeon General's here. But before I get there, I just want to make sure that, and this gets back to the point that Elliot Sorrell has made over and again about what Elliot called total health. We have really pushed in our institute for integrated mental health and primary care. But if you integrate it in the context of public health, then you get what Elliot calls total health. So what is public health? And I don't know how you define it, but it's a very important definition. It is what we do collectively, what we as a society do together, collectively, to assure the conditions for people to be healthy. So that word conditions, which was a major part of the report on social determinants of health from WHO, and I was on that commission, but the word conditions was our major definition of social determinants of health. And we'd like to take credit for that, but if you go back to 1988, the WHO, or the Institute of Medicine report on public health, defined public health as what we do as a society collectively to assure the conditions in which people can be healthy. What are the most important conditions? Well, I want to talk about that a little later. But I think all over the world people are familiar with the Surgeon General's report on smoking and health. The Surgeon General's position has been around since 1873 in the United States. And the United States is technically the only country that has the Surgeon General's position that's defined as a position that operates independently based on the best developed science. Now, that doesn't mean, as you probably have determined, that the Surgeon General can't be fired. But it means that the Surgeon General is supposed to be committed to being fired if necessary. My good friend, Joyce Elder, likes to talk about that. But in 1964, after over 100 years of the position of Surgeon General, in 1964, Luther Terry released the first ever Surgeon General's report. There had been no such thing as a Surgeon General's report. The Surgeon General was head of the Public Health Service. The Surgeon General oversaw all of the employees of the Public Health Service. But then the Eisenhower administration came along and created the Secretary of Health and Human Services. So the administrative role of the Surgeon General was somewhat diminished, but I think it turned out to be a good thing. And one of the great signs of that was in 1964, when Luther Terry released his report on smoking and health. Now, you probably know that research has been done all over the world showing some of the dangers of smoking. and health. You probably know that it wasn't the first time that there had been research showing that smoking could affect the heart and the lungs. But nobody had pulled all of this research together to make a policy point. And I think that's one of the ways to define the role of the Surgeon General is how do we look at the research and expedite action to impact policy. That is the greatest contribution that the Surgeon General makes. Now, in January 2014, we celebrated the 50th anniversary of the Surgeon General's first report, Smoking and Health. 50 years. So the question we raised was what's happened in the 50 years since the first ever Surgeon General's report. And it was interesting. Regina Benjamin was Surgeon General at that time, and the report that was released was the largest report ever released as it reviewed the history of smoking and health in the United States. Among other things, while about 20 million people had died from the effects of smoking between 1964 and 2014, it was estimated that over 10 million lives had been saved because of the Surgeon General's report. Why? Because of all of the people who quit smoking and the people who decided not to begin smoking because of the Surgeon General's report. So it's one of the great examples of the impact of a report. But the question is, how do you get from doing a report and getting people to stop smoking, and a lot of policies in between them, right? In '72, there was a policy that said you can no longer advertise tobacco on TV. You can no longer sell cigarettes to children. And 90% of people who begin to smoke before they're 18 years of age. So the policies that develop, and there have been many of them, including the more recent ones, having to do with smoking in public places. In our country, California was the first state to outlaw smoking in public places. But in 2003 and 2004, the World Health Organization held a global conference on smoking and health because the concern was that many of the advantages of the programs in the United States needed to be globalized. And so the World Health Organization held its first ever really treaty dealing with health. And the outcome was many countries signed on to an agreement. 150 countries signed on to an agreement that related to smoking and health. And it included most of those policies that have been passed in the United States, especially those that related to teenagers and smoking. So it's one of the best examples. So that's what we had behind us, if you will, when we released the Surgeon General's report on mental health. Now, I released several reports to Surgeon General, but I want to point to a few of them here and then to focus in on the mental health report. Of course, the reports on women and smoking, sexual health we mentioned, overweight and obesity. But I believe of all the reports that we released, I don't think any report has received as much attention as the mental health report. I get more invitations to speak about the mental health report than any report that I've released. And it gets back to something that Elliot said earlier about not leaving mental health to mental health professionals. I think a lot of people's attitude was, well, this Surgeon General is not just promoting his field. He's not a psychiatrist, even though I'm now a fellow in the American Academy. Let me figure it out now. But anyway, the point was that it was not self-serving. It had to do with public health. It had to do with health. And because of that, people like Patrick Kennedy, and then if you can imagine that Republicans and Democrats got together across party lines. Pete Domenici, a conservative Republican from New Mexico, Paul Wellstone, one of the most liberal Democrats from Minnesota, and Paul unfortunately died in that airplane crash. But they got together and passed legislation with Patrick Kennedy really providing the push. They provided legislation for mental health parity. And in 2008, when the legislation was passed, it was called the Mental Health Parity and Addiction Equity Act. I remember being asked to go to Washington and to help with convincing senators to vote for the Mental Health Parity and Addiction Equity Act. And I was scheduled to see Patrick Kennedy, but I was also scheduled to see his father, Ted Kennedy. And it was strange because there was something going on between them and nobody had explained it to me. So when I got to Senator Kennedy's office, he said, "Now, Dr. Satcher, I could get this law passed if it were not for my son." And I said, "What do you mean, Senator?" He said, "Well, if we could take this addiction equity out of the legislation, we could pass it." And I told him, I said, "Well, in this case, Senator, I agree with your son, because from our perspective, addiction disorders are mental disorders. They deal with the brain and how different people respond to drugs dealing with the brain." So ultimately, the legislation passed, and it passed as the Mental Health Parity and Addiction Equity Act in 2008. In addition to that, of course, in 2010, when President Obama's Affordable Care Act passed, he added to that the mandate that insurance companies would have to cover mental health problems the same as they did any other health issues. So prior to that, an insurance company could say, well, it's equity, but if we don't cover mental disorders, then we're not subject to the Equity Act. We don't cover mental health, so nobody can say you're not covering it at the same rate as you cover cardiovascular disease. So President Obama in the Affordable Care Act included making sure that insurance companies had to cover mental disorders, the same as they did any other disorder. They had to cover it, and they can't say we don't cover mental disorders. But I'm only saying that because I think when it comes to parity, these are really critical issues. These are the 4 Surgeon General's mental health reports, and I won't go into detail, but as you can see, the main one is mental health, the report of the Surgeon General, which I said November, and it says here December. So somebody's disagreeing with me by 1 month. That's that. Children's mental health, 2001. A very popular report, and the one that people have shown a lot of interest in, is mental health, culture, race, and ethnicity. And I can see how that report will have a lot of relevance to what you're trying to do here in Africa. It has to do with culture. It has to do with the fact that the culture of the patient affects how they respond to mental disorders. When and if they seek treatment, where they seek treatment, relates not only to the illness, but the culture. But it doesn't stop there. The culture of the physician affects how physicians respond to mental disorders. And if the culture is wrong, often the diagnosis is wrong. The story that was included in the Institute of Medicine's report about, this is a black man who drove a truck, and he drove throughout the country, and he was really suffering from depression. So somebody finally persuaded him to see a mental health specialist. And when the psychiatrist asked him to explain how he felt, he said, well, it's like when I'm driving across the country in my truck, the devil is sitting on the seat beside me. Now, if you came up in a black church, as I did, you understand that, right? Well, the psychiatrist diagnosed him with being schizophrenic because he was seeing things that were not there. and because he didn't understand the role of his religion, in his illness. So culture, well, I could give many examples, but that's one that was included in these two medicine reports. So mental health, culture, race, and ethnicity is a report that I think is going to have a lot of relevance to what we're trying to do. Now, this is Patrick Kennedy. Patrick Kennedy has now written a book entitled The Common Struggle. I don't know if any of you have read that book, but Patrick writes about his own struggle with mental disorders and with drugs. And by the way, something very special is happening today. Today is November 17th. Yeah, I think the Surgeon General is releasing the first ever Surgeon General's report on drug addiction today. I take comments on it before I left. So I will not be missing in action. But I think it's very important. Vivek Murthy, who has been Surgeon General now for about a year, and I don't know what's going to happen to Vivek with the new administration. But I think he's done a great job, and I think this report may be one of the most important reports issued by the Office of the Surgeon General. Opioid addiction, by the way, is now the leading cause of death in the United States, more so than motor vehicle crashes, more so than homicides. So we've come to a point where drug addiction has emerged as a major cause of death in our country among young people. Now, I don't go into a cultural issue here except to say that in the 80s, of course, crack cocaine came to America. And that was primarily in the black community. People who could not afford cocaine before could afford crack cocaine. And so it became like an epidemic. And what did the United States do? It filled its jails and prisons with black men. And even today, that's continuing. So it's really interesting, and I think fortunate in a way, that now that we're dealing with opioid addiction, which primarily affects whites, we're beginning to look at this thing differently. And I think the Surgeon General's report will take us even further toward asking questions about how do we respond, to addictive disorders? Do we respond to them as crimes, or do we respond to them as health problems? So when you get a chance, I'm almost sure that report is out today. Take a look at least the summary of the Surgeon General's report on addiction disorders. This is, I don't know how you define mental health. We define it from the standpoint of function and being concerned about whether people are able to be productive in their activities, whether they are able to develop fulfilling relationships with other people, beginning with their family, whether they can successfully cope with adversity, and they adapt to change. After the Hurricane Katrina in New Orleans, we were asked, the Satcher Institute and the National Center for Primary Care, to help rebuild the health infrastructure of New Orleans. And one of the things that was very obvious was that depression had tripled in the population that was most affected by Katrina. It had gone from 10% to 30%, because we screened for depression. So I think adapting to change and coping with adversity is certainly one of the real tests of mental health. There was good news and bad news in our report. The good news was that research has improved our ability to recognize, diagnose, and treat conditions effectively. That 80 to 90% of mental disorders are treatable using medication and other therapies. There are some people who disagree with that, but that's what the research shows. And of those with mental disorders, fewer than half of adults get the help that they need, and only 1/3 of children. That's how bad the situation was, and that's how bad it is. It may have improved a little bit. I think for us, one of the major ways it's improved has been the integrated care model. About 5 years ago, the Satcher Leadership Institute took over mental health emergencies at Grady, one of the largest public hospitals in the country. And we basically said, you know, if the state gives us money, we will take over mental health emergencies in the hospital. And we did. We were able to show that we could reduce waiting time by 80%. We could reduce the use of restraints, chemical and physical, by over 70%. And what I think surprised everybody is that we actually could reduce the cost by 40%. So there are a lot of integrated care models throughout the country and the world. I know the Carter Center has a major model in Liberia. But I think that the emergency room model, which we developed, and Glenda Wren directed that model, has been one of the most interesting and in some ways challenging, but clearly we've been able to show that using a team approach, we can in fact provide better quality care in mental health services. Every patient who comes in has access to a psychiatrist as needed, but no patient is sent out without getting care. You know, like sometimes we refer patients to, I want you to see Dr. Jones 3 weeks from now, and almost never do they keep those appointments. So we don't do that. They're seen immediately by a team that includes mental health specialists, and if they're not there, of course, it's coordinated. So it's interesting. The stigma issue, which we mentioned earlier, is really one that we're struggling with and will continue to struggle with. I think we've made some progress with stigma since the report came out. And certainly we've made some progress with policy, without question. I'm going to go on to finish. So what does this have to do with the social determinants of health? In 2004, after I had left government, WHO asked me to participate on a panel of 24 people who would go around the world and look at social determinants of health and to really examine how these social issues were impacting health status. So we went all over the world. We went to Japan, China, Australia, several places in Africa. But in every case, looking at the issue of social determinants of health. And our findings were, of course, you know what I said earlier, that social determinants are the conditions in which people are born, grow, live, work, and age. But if you go back to 1988, you will see that public health was in fact defined in 1988 as the collective efforts to create the conditions in which people can be healthy. And it doesn't bother me at all that that was not new. That finding had been hinted at before, but I think raising the social determinants to a new level is what's critical. Well, social determinants are shaped by the distribution of money, power, resources at the global, national, and local levels. In the United States, that says a lot about disparities in income, disparities in education, disparities in access to care. All of those issues are distributed in basic resources. But it also says that if you're going to change the social determinants of health, you're going to have policy change. Almost invariably, if you want to impact the social determinants of health, you've got to have policy change. I'm going to skip over these except to remind you of some of our experiences in global health. I'm sure you're familiar with some of them. This is the tobacco one. By the way, there was a time when the United States was right up top in terms of deaths attributed to tobacco, and as you can see, how that's really almost stayed level and is continuing to decline. But I think the good news is that in less developed countries, because of the WHO treaty, I think we're going to see a similar rate of decline in deaths from smoking. Now, we hold that addiction disorders are mental health disorders. They are not always diagnosed as mental health disorders. And of course, I know that I think this is from Sampson, looking at diagnosed mental health disorders and diagnosed addiction disorders and how they often overlap. And that's very important, and it's interesting to see how that's dealt with in the Surgeon General's report. So what would it take to eliminate global health disparities, including mental health disparities? Well, I think it would take a global commitment invested in global leadership, such as the WHO treaty. And I'm embarrassed to admit the United States did not sign that treaty. If you know what we've been dealing with in our Congress recently, the idea of signing something that would give authority of a body like WHO is something that we've had trouble getting this Congress to agree to, but the United States financially supported the treaty. It's a global sharing of resources, including knowledge, as demonstrated by the expanded program of immunization, one of the most successful stories that we've ever had in public health, immunizations. And two, a global intervention strategy, HIV/AIDS, polio, TB. A global agreement on policies to protect, all of those things are critical. The McKinney model is what we call a strategy for policy implementation. It starts downstream, it starts with services, it starts with research. There are changes in the community, maybe at schools, maybe in parks, and then it gets upstream. Upstream is not a place, it's a function. It's where policies are made. But then once policies are made, they have to be implemented. So it takes you right back down midstream and downstream. As I've talked about the Affordable Care Act, and I'm really hoping that Mr. Trump, who seems to be a little uncertain about what he's going to do about it, I hope that these three things will remain. The Affordable Care Act will expand mental health and substance use disorders, benefits in America, protection for over 62 million people. Now that assumes that every state would expand. Most health plans must now cover preventive services like depression screening for adults and behavioral assessments. Finally, starting in 2014, plans were not able to deny coverage. Well, let me close by reminding you of the motto of the Satcher Leadership Institute. And we have a prescription having to do with physical activity. But the motto is that in order to eliminate disparities in health and achieve health equity, we need leaders. We need leaders who care enough, know enough, will do enough, and leaders who will persevere until the job is done. Thank you.
Wow, thank you, Dr. Satcher. That was truly a historic keynote lecture on the interrelationship of science and policy, and it really sets us up for trying to make inroads on these very important problems. That was really spectacular. Thank you, Dr. Satcher, for being here and for helping to inspire us. Also, I was remiss. I wanted to thank Moshadi and Banga and Michelle for doing the heavy lifting in getting this whole gathering together. Thank you, guys. I've been thinking about Dr. Satcher and earlier about Chet Pierce. They really are paterfamilias in their own way. Dr. Satcher, for us in the United States in global health, and Chet really was a paterfamilias for African American psychiatrists. And I have the privilege of introducing Atale, who's a friend from many years ago. And I've been an observer of Ethiopian psychiatry, and Atale is truly paterfamilias in terms of Ethiopian psychiatry. And I've been just amazed at the progress in Ethiopia in terms of mental health over the last 15 or 16 years. And Attila has been at the forefront. He's a professor at Addis Ababa University. He was in charge of the whole health sciences college there for a long time, and I know he's told me personally he's so happy now to be back taking care of patients. So, Attila, without further ado.
Thank you, Greg, for that introduction. Good morning, everyone. I think we are now ready for tea, not listening anymore. Talk. My role is just to highlight a few things and comments of the talk and also what I think this meeting would eventually come up with, and then invite you to ask you questions. I'm impressed by the Dr. Satcher talk about leadership. I have really a good quote now for me to take home from his speech, that the need for leaders is to get to leave their emergence to chance. How true that is. It's a very true statement, because leadership takes careful mentoring, role modeling, and recruiting people who will take over to the next generation. Leadership that has been started by certain individuals sometimes stops there and starts all over again. That is a trend in our continent especially, because our transition is never smooth in this continent. Leaders want to stay forever in their positions, and then uprising comes and they will be overthrown, and there is no institutional memory. Then the next leader has to start from scratch all over again. And so our countries on this continent are always beginners as new governments, new leaderships come. And the same is true in the scientific field and in mental health leadership, where leaders are very scarce in this continent. So I think what we learn from this talk today is that we, current leaders in our respective countries, the main role we have is, as our age advances and we'll be forced to leave our positions way ahead. Before doing that, we have to really recruit and coach and train and show role modeling to our next leaders. And the other point that impressed me was that deeply held beliefs influence policy better than evidence. How true this is in our continent. You know, we've been conducting research over the last 20 years and trying to influence policy, bringing evidence, data from our own countries. But those evidence that we've been able to generate have not very much influenced policy. And we have to, however, keep on knocking to waiting for a time, as this has been the case in the United States also, when the Mental Health Parity Act started in 1999, And it took another 9 years to be enacted in the United States, where we think evidence would be taken just immediately into policy formation, but still requires there. How much more do we need to do in this continent? And be patient until change comes. Disparity in mental health is really a world global problem. The stigma attached to it, not only by the general public, by our fellow health professionals. Recruiting doctors to do psychiatry as a career is a big, big challenge in our country because of the stigma attached to it. But I think it is our role as leaders to patiently pursue this issue until it comes to fruition. And we are seeing this. This afternoon, we're going to discuss about this, and I'm going to talk about how possibly we can create a critical mass in our respective countries in terms of leadership and mental health professionals. So, so many things have been said here, and they're all really pertinent, and I'm very glad. And one thing that I got delighted with by the talk of the former Surgeon General is that I was struggling to understand what the role of Surgeon General. We see a Minister of Health. Now I've got some clue. And I would like to understand more by asking you, Dr. Satcher. So I'm very glad to be here today. And the other thing, the very impressive thing, is the definition of mental health that is put in the DSM-4 was taken from Surgeon General's definition. And this definition I have been using to teach my students for many, many years. And now I happen to be in a meeting where the person who defines this. So this is really a great moment for me. So, and this is, again, really reflects what Prof. Elliott said earlier. Mental health should not be left to mental health professionals. I understand Dr. Satcher is not a psychiatrist, or maybe he's not, but he's done a great job. So I think this is also one of the things we learn from this. And we cannot satisfy the need and the demand for mental health care by trying to do it all by ourselves. We have to integrate mental health, and we have to also influence others to take part in the care of community health. With that said, I would like to invite questions if you have for discussion, and then we'll break for tea. If you want to have tea as soon as you raise questions and raise the hand. Yes.
I have a question for Dr. Satcher. Well, first of all, thank you for everything. For me, the Surgeon General's report, and especially culture, race, and ethnicity, is a Bible. It's a Bible I use to work with families, and I thank you for that. What really came to my mind as I was listening to your lecture today was the Surgeon General's report that was done on tobacco in 1964 and your report that was done on mental health. The highest population of people smoking in the United States now are seriously mentally ill people. We are giving people nicotine in psychiatric hospitals. They're going into the hospital, non-smokers, and coming out smokers. And I'm wondering, do you see that as a public policy issue, and what can we do to correct that? Is there a way to mandate that hospitals not allow smoking? I mean, I understand the concept of nicotine receptors and all of that, but again, we're creating addiction in people who already have brain disorders.
You want me to answer? Well, it's interesting, and one thing I didn't say, and it was probably on the slides, but I was going on a little long. You probably saw on one of the slides where it said that people with mental disorders have a life expectancy that's 25 years less than the rest of the population. It's chronic diseases. Obesity and smoking are two of the, I think obesity is what, 44% in people with mental disorders. So if there's no other area where we need to integrate care, this is certainly one of them. I think there are many areas, but I'm glad we started here in many ways. People argue that, they used to argue, I don't think they argue that anymore, that the smoking was a part of the treatment. Do you guys still argue that? Yeah, they used to argue that smoking, so there's a lot of history behind that. But I think it's totally inappropriate, and I think we've really got to focus now on how can we help people be healthy, mentally healthy, physically healthy, and see how they go together. But there's certainly, as I understand it, a history where some people view smoking as a part of the therapy in treating mental disorders. So some of you may have been around, I don't think many of you have been around longer than I have, but, so you probably remember when some people use smoking as part of the therapy for treating. I think that's, we now know that that's not fair, and that, as I said, the average life expectancy, for many reasons, that's one of them, is 25 years less than the rest of the population, average. But I don't think there are any policies that mandate it, but I think mental institutions may have found a way to get around some of the rules about smoking that others have been subject to. But I mean, I don't know what the rules for smoking are here. I mean, there are parts of the United States where you can't smoke in public places, and airports and stuff like that, even though. So I mean, we're still struggling with this public health issue, but it's really important that we take a public health approach. Mental health has to be placed in the context of public health, and we have to see how we can all work together, to really give people the best chance to be healthy. You didn't even hear the question, Elliot.
I have another question. You emphasize the importance of access. Key question, before you even go to discrimination, that's stage 2, access. We now have a global health professions deficit. Health professions meaning, of course, professions, not just doctors, of 7 million. Unattended to, by 2030, this deficit will be 15 million. So I think that that's one aspect. The other, in the richest country in the world, the United States, health, whether it's a right or not, is still being debated. And some people don't even accept discussing it, that it is not a right. It's off the table. So we have these two major challenges that have to do with health workforce and is health a right or not? I was very pleased to see 2 days ago a group of former international health leaders sign a joint document that will be forwarded to the WHO. I was surprised though that WHO, in case you don't know, WHO is not an executive organization. It's an advisory organization to the member states of the UN. And forgive me for making one more parenthesis. Dr. Satcher and I were very excited in 2011 when we saw that non-communicable diseases will be on the agenda of the UN General Assembly, thinking that they will all be included, but mental disorders or not, they were excluded. So we need to come back to this issue of access and the health workforce. 2 days ago, a group of leaders signed a joint document that the next challenge for the next the Director General of the WHO would be to facilitate a global treaty on access to care, universal access to care. Well, I think the idea is good, but it won't be done through the WHO. It has to be done, and even at the UN. The UN is an advisory body to member states. Whether the member states will agree to follow, even there is an accord, is another question. But I think it's worth bringing this issue up, and I'd like to hear your comments, David, on both linking up these three things: access, workforce, and a global treaty. On access.
Well, no, I mean, I think that's the beauty of the tobacco treaty. That really was the first ever treaty conference that WHO had ever held. And as you point out, the power of it is when the countries sign on. And when the United States doesn't sign on, it doesn't mean the United States is not committed to those things, because the United States had many of those policies in place. And many of the things that came out of the tobacco treaty thing were based on policies that have already been passed in the United States, like smoking in public places, advertising to teenagers, stuff like that. So no, I agree. I mean, I think despite the lack of authority of WHO, there is an authority that goes with numbers. So you have 150 countries signing on to a treaty. It carries some weight. And as I said, I mean, the United States is stubborn in that sense, but still, the United States also is ahead when it comes to policies related to that. The treaty is going to have the most impact on developing countries. But when it comes to access to care, that's long overdue. I mean, what is it, 90-something% of countries have health care as a right, and the United States is one of the few that does not. And obviously, what Obama was trying to do, I'm speaking about the Affordable Care Act, because I know it wasn't just Obama, was to say that we believe that everybody should have access to care, but we're not going to develop single payer because we know it will never pass Congress. You know, so we're not talking about single payer. We're talking about a public-private kind of strategy that will assure that 90-something%, and we're at 92% of Americans now are covered with insurance. It was, what was it, 84% when this all started. So it's really interesting to watch this evolution. But yeah, I think when it comes to access, we're long overdue for that.
Any other points?
Ron Bailey from North Carolina. I'd like to comment actually to Nancy Carter's point about the trouble with blocking smoking in settings. I actually ran the Elam Hudson in Mary College for about 8 years, finished a couple years ago, and we spent just an enormous amount of time trying to decrease in smoking in the health center, for all the reasons that I think you so articulately point out. And there are really three loopholes that I think are struggles around the country. First and foremost, becomes an issue legally of substantive due process. You can't treat one group, mental health patients, in a hospital setting with state and federal funding differently than other groups. If you don't block smoking in all hospitals, we have received a fine that you really couldn't block it in a state-funded mental health center. The other issue is that on our premises there actually was a bus stop. And bus stops are viewed as a very different geographical location. A person could actually go to the bus stop and smoke. All the Meharry block smoking at all the Meharry facilities. You could smoke in the hospital at Meharry, any of them, all on the premises, but you could smoke at the bus stop, which was within our perimeter. And the third part, I think, actually, there was funding considerations. We actually had a risk of threat of losing funding if we continue to push it. So the issues become remarkably political that I think are substantially adverse to what you're trying to do. I think what your point is to do what you think is in the patient's best interest from a healthcare domain. There's probably one, I think, microcosm of these struggles we have, take care of patients with mental health problems, I think, around other domains, I think, as well.
saying, but signing treaty on such issues is easier than implementing it.
Very important.
Ethiopia signed this treaty many years ago, but to implement it, take it to the parliament and enact it as a law took many, many years. Probably Ethiopia is the last country to put it as a law against smoking in public places. And that started to be implemented in hospitals, including mental hospitals. It's a big, big stride.
That's true.
Yeah, and how to implement that, I really don't know. But we don't, of course, prescribe nicotine guns, and we don't have it in the country, so we can't prescribe nicotine. But we tend to prohibit that, but applying it is very, very difficult.
Just want to make a brief point.
Just a very brief point. Dr. Satcher has demonstrated through the institute, Satcher Leadership Institute, that leadership is a team sport. But I would say policy related to it, in addition to having a team, policy development and implementation is an endurance sport. It's a marathon sport.
Well, we said so long distance run.
Right, long distance run.
Long distance run.
Just-
a relay race.
Right, now the perspective that I want to give, it's not just Ethiopia, United States. The first intention of parity was expressed in 1996 by the same two senators, the Domenici-Wellstone Amendment, 1996. It took 12 years, 2008, to to sign the law by President Bush, 2009 by President Obama to implement it. We're now in 2016, and the regulations for monitoring it are still being kind of shaky. So, 1996 to 2016, you figure 20 years, and it's not quite 100% humming. And that's United States of America. So, not that you should just take us as an example, but we're not an example to emulate. But I think it is extremely important not to give up, even when elections not go with your candidate. You got to persevere. You got to be there. And you got to influence the process. Don't give up. And don't focus on the person you don't agree with. See how we can make the difference. So that whatever the issues that are important to our patients get done, regardless of who is at the top. Thanks.
Yeah. That's such an important point, Elliot. When the election took place the other night, of course, I couldn't bear to sit through that, so I went to sleep. Woke up the next morning to the news. But it reminded me of when Al Gore and George W. Bush were running, and you remember Al Gore got more popular votes, but he lost Florida. And all of Clinton's people were packing their bags to leave, of course. And I just decided that, well, the Surgeon General's term is independent of the president's. And I think I would be doing the office a disservice. So I went to see President Bush, and I basically said, I just want you to know that I have another year left on my term, but I know you want to appoint your own Surgeon General, so I'd be happy to step down. And he said, no, David, I want you to stay on and serve out your term. In that year that I stayed, the report on overweight and obesity, which is another major report in the United States, came out that year. Never would have been released if I had not stayed. The sexual health report never would have been released, right? So I could go on, there were 3 or 4 that came out because I stayed on with George. In some ways, I was able to get some things done with George W. Bush I couldn't get done with Clinton, especially the sexual health thing, but I won't get into that.
It's a touchy subject.
It's a touchy subject.
Yeah. But, so I just wanted to follow up on that. That's very important. It's very important that, and that's also why it's so important that you have a position like the Surgeon General, which is not subject to every political administration.
Yeah, I'm Gordon from Ghana. Just to touch on Dr. Atale's comment on implementation failures on the continent. Just want to share with you a bit about the Ghanaian experience, briefly. On tobacco, for example, we had a pathologist whose singular effort has now led to a more or less an unwritten policy of not smoking in public. He subsequently became the Director General of the Ghana Health Services, more closely related to the Surgeon General. He waged a war on TV against smoking, threatened to go to court, use all the resources available to him. Eventually, people started stopping to smoke, and people will go up to people smoking in public. That you should stop smoking because I'm at more risk than you. So now you don't see people smoking in public. Like when I was growing up as a child, a teenager, I would see people smoking in other places. People actually hide to smoke if they do smoke. And that has become, even though it's not a written law, it's in the books though, but more or less like an unwritten policy. And that seems to be the case with Ghana, where individual effort and group efforts tend to move faster than the political efforts. Unfortunately, with regards to mental health, is the opposite. Our mental health leaders have tended to rely on the politicians. Unfortunately, too, for us, the politicians have tended to rely on us for advice. And another unfortunate bit is when it comes to mental health, we allow industry to dictate. And that has been the dilemma that we find ourselves. And therefore, for example, with cardiothoracic surgery, it also was an individual effort by the now legendary Professor Frimpong Boateng, who established cardiothoracic surgery in Ghana. He came back and tried to get into the institutions. And my hospital was the first to throw him out on the assumption that Ghana was not ready for cardiothoracic surgery. And Ghana is never ready for anything. We're not ready for a modern airport. We're not ready for anything that goes with modernity. So what did he do? He decided to set up an independent center. Even though it's within the premises of a premier hospital, it has nothing to do with the premier hospital. And he fought and made it what it is, an African center of excellence now. So it's something that I want to bring to the attention of Dr. Atala and the rest of us. If you can comment on the individual and group efforts regarding mental health and how to utilize this point to move ahead of politicians.
Yeah.
I think it's a very important point. I think I was in Ghana, I don't know if you remember when the Institute of Medicine had gotten some private money to set up academies of medicine in African countries. And Ghana was one of the places that I was sent to examine. So, you were there, okay. But as you remember, one of the biggest issues was the young physicians were leaving, and that's why we didn't recommend the establishment of the academy, because the young physicians were leaving. Now you could argue, well, maybe if there was an academy, it wouldn't. But I agree. But the other point, though, which is so important, even when there are policies, like the California policy against smoking in public places, the impact is based more on what you said than it is on policy. It becomes not cool to smoke. There was a time when it was cool to smoke. I mean, people, you wouldn't be comfortable if you didn't have a cigarette. And now, of course, first you pass a law against smoking in public places, then people get really upset when they see people smoking. They say, well, I deserve to be healthy. So you're absolutely right there. The individual reactions can be very critical in terms of policy. So I'm trying to think of the best word for it, but it's not unintended, but it's sort of a side effect of policy. And what you're saying is sometimes that impact can happen before when the policy can happen. You're absolutely right.
Question? David?
Yeah, any other person before Elliot visits us? Your student wants to ask.
No, my student comes first. She comes all the way from China via Washington.
I guess this is a question for, two parts of the question are for everyone here because you're all doctors. You all work in the field of mental health. So I think a part of what Dr. Satcher said about cultural barriers is very important in treating mental health illnesses. But what do you think is necessary in breaking cultural barriers? From my part as a student, I think education on whether doctors to be or public health professionals to be is crucial, but it is integrated in education, like in the education system of either African countries or United States. And also a second part of the question is I recently read a book by Anne Fadiman. It's on the Hmong community in Merced, California. So I was really inspired by how sometimes the egocentrism in Western medicine of the Western biomedical system can be harmful or hinder, the treatment of mental health patients. Yeah. So how do you think we can integrate, for example, indigenous treatments, for example, like shamans or spiritual healing with biomedical treatments? Do you think that is I think definitely important? And what can we do as countries like African countries or even the United States? And what efforts has been done?
I'm sure somebody else wants to comment, but I think that's one of the potentials for integrated care. And we have a person, in fact, Keisha Holden, who is the interim director of Satcher Leadership Institute, has a special project looking at integrating culture into the care of patients, not just integrating primary care and mental health, but integrating community and culture. I think it could be really critical in Africa, especially that we find a way to integrate culture. And I'm sure they're doing it in Liberia, for example, where the Carter Center, you might want to look into what the Carter Center is doing. If you're having trouble, just let me know. Tom Borneman at the Carter Center is leading that effort. But I think clearly we have to find a way to integrate culture, and I think that's one of the side effects, if you will, of the integration, is that we're not only bringing in primary care along with mental health, we're also training people on the team who bring the community culture. And so that's very important.
I'm Alpha Stewart from Memphis, Tennessee. Dr. Satcher, thank you for your usual thoughtful and thought-provoking presentation. Your slide that had upstream, midstream, and downstream. Upstream always reminds me that we tend to forget children in the spectrum of mental disorders. And your report, your Surgeon General's report on children's mental health, I think, was another one of those seminal reports that reminded us that children are not simply small adults. As someone who's not a child psychiatrist, but has for the last decade or so worked in children's mental health systems of care, and knowing that a lot of the upstream work that we might do in support of improving children's mental health bodes well for later in life, particularly around exposure to violence and trauma and those kinds of things, in addition to the general mental disorders. So your thoughts on some of the things we're still not doing that we should be? I work, for example, with children who are in supervised care, juvenile justice, child welfare systems. And we know some of the impact of the exposure to those systems alone has on their health and well-being. Your thoughts on some other things we should be incorporating? We do a lot with childhood exposure to violence and trauma-informed care, and pediatricians are doing universal screenings around mental health, which is a step in the right direction, but just some general thoughts on other things.
Well, my favorite, and please don't tell anybody, my favorite program at the Satcher Leadership Institute is the Quality Parenting Program. We have a program in which we take about 100 parents from the community. Most 80% of these are single parent households. And it deals with child development from 0 to 5. We talk about the brain and why it's important to communicate early with the child, even during pregnancy, by the way. And the effect of nutrition, the effect of avoiding violence, in the home. But all of those things that we believe impact the development of the brain of the child is something that we include in that program. And I just, we can complain about the fact that 80% of our households are single parent, or we can figure out how we can be more supportive. I mean, if those parents have that responsibility, then what can we do to really help? And so we decided to start this program. We've just been funded by NIH to replicate that program in 12 states. Now, I may not be answering your question. I'm guilty of that sometimes because my memory is not always as good. But I think parents are a critical part of this equation. The other report that I released as Surgeon General was the report on youth violence. It was the only report I did that was requested by both the President and the Congress. And you know why? When Columbine took place, and I had just become Surgeon General, that was our first major mass shooting, especially involving children. And all of these kids were killed or injured in that shooting at Columbine. And when I became Surgeon General, I visited the kids there and all of that, but Congress and the President said we need a report. In other words, the American people were up in arms. They were really upset about this shooting. And so the Congress and the President, the White House wanted to really respond because they wanted people to settle down. And so we did the report. By the time we finished the report, of course, the American people had already settled down. You know how we move on to something else? That's what, so that had happened. So it was not easy to implement. One of the things that we concluded was a recommendation having to do with the use of nurse practitioners and how they would do home visits for 9 months or so. And it was documented that in those communities, violence went down by 50%. It was really interesting. But a lot of it got lost, and we moved on to something else, if you will. But it's still there, and we're trying to incorporate that into our institute called the Parenting Program.
Okay, we take 2 questions, 3 questions. I think time for David, yes, and then Greg and Pamela.
Yeah, thank you very much, Adelaide. I just want to agree with that statement. It's such a powerful statement, and especially when it comes to alcohol, to tobacco. There's one person who cannot, just one individual. His name is Professor Peter Dino, a cardiothoracic surgeon. He has pushed the issue of tobacco smoking in public to the extent that now there is a law, but the people who implement that law is not really the law, the government. It's the people who have decided that smoking is not acceptable in the public. And although you can be arrested in Nairobi for smoking in a public place, it is the general population who will arrest you and tell you you cannot smoke. And if you get into public transport, and he starts smoking, then he stops, can't move on until that person is thrown out. It's extremely powerful because of one person. Thank you.
That's really very powerful. I wish really our communities develop that kind of attitude to things that affect them, that affect the public. But in our culture, people just keep quiet and they don't expose people. Yesterday, a friend of mine was driving me around here and he did an unnecessary turn in a wrong direction. And everybody was blowing horn against him. That happens every day in my country, nobody does. And I think if the public really is fully aware of what is really harmful, what is unlawful, and our country is going.
So I just want to comment, Dr. Stewart, about you bringing up adverse childhood events. It's a great example of CDC and Bob Anderson's work, science and policy. And in Memphis, the ACES Foundation is an exuberant example of what can be done. We're really, it's amazing what's happening in your home city. But the reason why I raised my hand is because I wanted to put Tedla on the spot, because we're so blessed to have someone who's worked in the United States in an official capacity, and now is in Ethiopia and Africa working on mental health. So I'm wondering if he could give us the benefit of his comments.
Well, I never thought that I'd be sitting in the same room with Dr. Satcher someday, because when I took over in Washington, D.C., it was St. Elizabeth Hospital. In fact, we used to have a lot of PHS officers come out there. Your people out there with their uniforms, and sometimes we go their immigration officers, but we forgive them, you know. Anyway, that was our Bible, when you think about it. I took over the multicultural program, the international program in 1987, so it was in 2001. Your culture and race and ethnicity came out, so it was 4 years later. But that was our Bible, you know, when we were proposals, that gave us that legitimacy to develop the cultural competence programs. In fact, at some point, this cultural competence program, which I was leading, became part of a mandatory requirement for privileging and licensing. So it just kind of legitimized why people have to be culturally competent. So the same thing, you know, 6 years later when I moved to Ethiopia, after 47 years of serving in the US, you know, when you reach a certain age,
How old are you?
a few years left still. And then, so I became advisor to the minister. You know, one thing I realized was, you know, from my experience in the US with cultural competence, these type of initiatives just take time. The only thing that you don't do is just give up. So to me, even in the US, that movement in terms of cultural competence was there. So your report kind of legitimized it in a way. It was on paper, and it became enforceable to make it a mandatory requirement for training. In fact, we made it, everybody who was a health professional in the District of Columbia, St. Elizabeth's Hospital, has to have 8 years of cultural competence training in order to get privileged to practice. So what, to me, policy does is, it just legitimizes the movement that already existed. The same in Ethiopia. When I became, you know, advisor to the minister of mental health and international issues, so we're lucky to have a minister who was head of mental health before he became minister. So what it does is, you know, these policies that take time, energy and resources in terms of commitments, critical mass, when they are written, when they are exposed with the minister's signature, with your signature in terms of that, it just helps for people to take notice and say, hey, it's the right thing to do. And then it gives them the cover, the political cover to say, okay, we can expend so much money, allocating a budget and so forth. And from my experience, both in the US and so forth, especially in terms of integration of mental health. Even in the US, it's just a recent phenomenon. In the District of Columbia, we had Department of Mental Health, and we had Department of Addiction and Recovery Services. It was so hard to refer patients from one silo to another silo. It's just 3 years ago that they combined them. And then that's one mistake that we haven't done in Ethiopia. We have been trying to integrate mental health right from the beginning into the primary health care services. So with that said, it's an honor to be in the same room as David Satcher, which we used, your report to legitimize, our movement in terms of cultural competence, privileging, and including certification in terms of licensure. Because if you're not licensed, you can't practice. And people are interested in maintaining their license. So policies, although they need time, it just legitimizes the process and then gets credibility to our movement. Thank you, Dr. Satcher.
Well, thank you. I mean, whatever you've been doing, it says you've been no harm. You worked for 47 years, and you look like you're 47 years. I do want to say one thing, follow up on what you said, because I think it's so important, especially for young people. These things take time, but who was it? Oliver Wendell Holmes who said, more important than where a person stands is the direction in which he's moving. And so I've started to talk a lot now about the journey, to help that. It's a journey. It's not, you've got to enjoy the journey. You may not be there, but you've got to get rewarded by being on the right journey. The journey for integrating mental health and primary care. So I just think the whole idea of the journey and making sure you're on the right path and on the right journey, it allows you to be more patient, because it can be very frustrating. It can be very frustrating trying to get change that needs to be made. And a lot of people give up, they just get frustrated. But you got to see yourself as a part of the journey. You're on a journey, and as long as you're going in the right direction, there's fulfillment that comes from it.
First of all, I'm Pamela Collins from the National Institute of Mental Health in the U.S. I want to also just thank Dr. Satcher for his remarks and for his amazing contribution to mental health, despite not being a mental health professional, and maybe all the more so for that reason. I wanted to respond to this Elliott student who asked the question about traditional healers and so on. One of the things that we've been really interested in at NIMH is figuring out how do we establish a good evidence base for reducing the treatment gap, both in the U.S. for people that don't get the access to care that we're concerned about, but also in low and middle income countries around the world. And we're trying to look at some of these questions that you just raised. And there's Oya Gareje, who's in Nigeria, is doing some very interesting work on trying to actually test to see whether collaborations between traditional healers and primary care providers can yield better outcomes with respect to severe mental illness. So there's some interesting research happening around these things, and I think that's what we actually need an evidence base to see what really works and what we can build on based on that. So just wanted to follow that up. And then the other thing I know that this is probably one of the goals of this meeting, but we're also interested in seeing what happens with mental health policy implementation. And we have Ethiopia, we have Ghana here, we have South Africa. We've got the work that David Ndete has been doing in Kenya with respect to linking policy and research. It would be great for this group to be able to follow the trajectory of what happens as these mental health policies and actions are implemented. And for us to figure out what the research questions are that can really help us to learn from the policy intervention as well.
Thank you very much. Thank you for that. It's great to know that you're planning this.
Right. I think now and let me conclude by telling you one brief story about pursuing and being persistent in what we do. And a student of mine who I sponsored to go to Britain to do psychiatry, did psychiatry, specialized in child psychiatry and remains there, unfortunately. He didn't come back. He was telling me one story. When he was assigned in one of NHS trusts around Oxford, he met this guy who was leader of mental health section of the hospital, and he was telling him stories about people who came and left, and those people were not really in tandem with the policy and the vision he had, and they created this problem, and I made them leave, and I made them leave, I made them leave. And this guy asked him, because he was afraid, he himself was just a newcomer there, and he wanted to be careful, to know not to be really exposed. And he asked him, how did you make them leave? He said, by staying. So if we persevere, if we stay where we are and try to see what we started to go and to finish in line, then I think it will be paid. And that's what we most of the time lack. We try, and things did not happen now, and we think that it will never happen forever, and then we leave, and then everything was ground zero. And I think I would like to encourage all of us to stay where we are, and persevere until policies change and become favorable for mental services in our respective countries. Thank you very much.